Hello, my name is Jennifer Dorman, and I'm the clinical nurse specialist for the Rapid Response Team. Today I'll be talking to you about effective strategies for CPR management. So when do you need to call a code? A code 3, as it's called at Maimonides Medical Center, is called for cardiopulmonary arrest. So the patient has no pulse and is not breathing. A code 3 is also called when an arrest is imminent. An example would be agonal breathing and/or a weak or faint pulse. The Maimonides Code 3 algorithm: if you're the first person finding the patient unresponsive and pulseless, then you are to stay with the patient and begin CPR. You will additionally call for help, whether you need to shout out to your colleagues, to call the operator, and additionally get the code card. The second responder will obtain the code card and attach the pads. The RN will turn the defibrillator on and place it in AED mode. This is a mode that's used until the code team members arrive and allows staff to identify rhythm and shock if needed. Once the code team arrives, the defibrillator can be placed in monitor mode since the code team is available to properly identify a rhythm. When applying the OneStep Zoll pads, the most common placement is the anterior-posterior placement. As you can see, right here we have what's called the CPR puck, and this is placed mid-sternum at the nipple line. The CPR puck is what you will continue to do chest compressions on, and that will talk to the Zoll defibrillator and give you feedback on how you're doing your CPR. Team roles and goals. What you see here is a diagram of how it is recommended the code should run. First and foremost, you want to get everyone out of the room that is not associated with the code. Too many people equals too much chaos. So here you have the anesthesiologist at the head of the bed. They will be working with the airway along with the respiratory therapist. Ideally, there should be 2 compressors, one on each side. The reason we have one on each side is when you are ready to switch compressors after the 2-minute interval, it makes it easier if there's somebody on each side of the patient. The code team leader will be circulating around the room and should really be in charge of the code and not actually doing any tasks during the code. There usually will be 1 or 2 nurses circulating. That nurse can be giving medications, perhaps hanging some IV fluids. There will be a hospitalist at each code, and that hospitalist will be in the background making sure the code team leader is running the code appropriately. There will also be a rapid response RN also assisting. And over here you will see the code card facing the patient, and ideally there should be at least 2 RNs, one who will be anticipating which meds to draw up, and the other RN will be documenting each medication that is given. Important points to note, especially with compressions, is that you want to push hard and push fast. With each compression, you want to allow for full chest recoil, between 5 and 6 centimeters total. At Maimonides Medical Center, the Zoll defibrillator does have indicators that let you know how well you're doing compressions. One indicator shows you the rate, one indicator shows you full chest recoil, so you will be able to use these indicators in helping you with your chest compressions. And another point to remember is that the adult rate is 100 compressions per minute with an upper limit of 120. Another important point, of course, would be the airway. One of the most important things, you want to minimize interruptions in chest compressions to insert an airway. You want to continue to manually ventilate with bag mask valve, and you could also consider an LMA and other supraglottic airways. The ACLS teaching points. VFib and pulseless VTAC are the only shockable rhythms. The most common non-shockable rhythm that you do see is a PEA, is a pulseless electrical activity, and asystole. These are the 2 or 3 rhythms that you're going to be seeing the most with each code situation. So your shockable rhythms. Again, you want to remember the most important thing is CPR first, which is your good, effective chest compressions. Another point is that you want to continue your CPR while the defibrillator is charging. On average, it takes about 6 to 7 seconds for it to charge, so you want to consider that when you're doing your compressions. When you're about to shock the patient, you want to make sure that you're clearing. So you would say to yourself, I'm clear, you're clear, everyone is clear. At that point, the Zoll would be charged and you would activate the defib. At Maimonides, on our Zoll defibrillator, when you are shocking a patient who is in a VFib, the Zoll machine will default automatically to 120 joules. So the first shock that you give your patient will be at 120 joules. If you need to give another shock, it will automatically escalate to 150 joules. If there is a third shock, it will automatically escalate to 200 joules. Every shock after that third shock will continue at 200 joules. So it does make it easier. You don't have to worry about going in there and increasing or decreasing the joules. Very important, you want to resume compressions immediately following each shock. So once that shock is given, you want to immediately resume compressions. Don't worry about checking a pulse at this time. Epinephrine is the drug of choice for both shockable and non-shockable rhythms. You want to give that 1 milligram IV push every 3 to 5 minutes. If VFib or pulseless VTAC continues, you want to consider giving amiodarone 300 milligrams IV push times 1 dose. Your non-shockable rhythms, as we mentioned before, asystole. Asystole is associated with poor outcomes. It's a terminal rhythm that usually started with another rhythm. It's also sometimes the first rhythm identified in an unwitnessed code. So if you're walking in a room, it's a prolonged arrest, nobody has been in the room maybe for 15, 20 minutes, most often you'll see asystole. In this point, you want to look for reversible causes. If you're in doubt to whether a rhythm is VFib or asystole, an initial attempt at a defibrillation may be appropriate. Non-shockable rhythms, again, pulseless electrical activity. It's associated with poor outcomes, but it can be reversible. When you're looking at pulseless electrical activity, of course, you're going to see some type of what looks like an organized rhythm on the machine, but the patient is indeed pulseless. So look for your reversible causes. Think about your H's and your T's. Some examples: hypovolemia, hypoglycemia. Your T's: trauma, thrombosis, tension, pneumo. You always want to think about why this patient is coding and what you can do to reverse it. When in doubt as to whether the patient has a pulse, you want to start or continue CPR with effective chest compressions. Key points to consider: your IV or your intraosseous, your IO, is the preferred drug route during CPR. A central line is only indicated if you're unable to get a peripheral line. The IO is available in the hospital, throughout the hospital. There are trained members who can put in the IO. It's available during codes. It's available in the ICUs. It's available in the emergency department. Obtaining routine ABGs or any type of lab during CPR is not indicated. So for instance, if you think your patient is hypoglycemic, instead of running to get a BGM on this patient, you would automatically give that dextrose. You want to treat the patient for any suspected causes. Other points to consider: each time a medication is given or a rhythm changes, a full 2 minutes of CPR should be given to circulate that drug. You want to minimize the time that you're not doing compressions. Check pulse when switching providers every 2 minutes. That's the ideal time you should be checking for a pulse. And when you do check that pulse, it should not exceed 10 seconds, and you should be checking those pulses on one side of the body. You don't want to occlude both carotids, both femorals. It should be checked on one side of the body. So you want to keep that in mind. Let's talk about terminating resuscitative efforts, which comes up a lot when running a code. Certain things that you should consider is the time to CPR. How long was the patient down? Was this a witnessed, unwitnessed arrest? How long did it take if the patient was in a VFib? How long was the time to defib the patient? What kind of comorbidities does the patient have? What was their pre-arrest state? Were they already on vasopressors? Were they receiving the sepsis bundle? Were there other things going on with this patient? What was the initial rhythm? We talked about asystole being associated with very poor outcomes. And what is their response to any of those resuscitative measures? Did they have a change of rhythm at any point during the CPR that is being given? So in conclusion, one of the main important things is you want to stay focused on your uninterrupted chest compressions. Only check for a pulse when switching CPR providers every 2 minutes. And do not check for a pulse immediately after defibrillation. You want to continue that CPR. So I want to thank everyone for listening today. And just as a follow-up, if you would like to arrange a mock code on your unit, please contact myself, Jennifer Dorman, at extension 8148. Thank you.